Good afternoon, everyone. I'd like to take my turn and thank Dr. Faliakou for the invitation and for an excellent two-day conference. It's an absolute pleasure to be here. So, like Dr. Masterakos mentioned, I'm switching gears a little bit, talking about autologous breast reconstruction. I was asked to talk about advantages and disadvantages. The outline, so I'm going to talk a little bit about breast reconstruction as a quality indicator for breast cancer care. It is becoming an integral part of breast cancer care now. Very briefly on timing, types, and goals of breast reconstruction. And then focus on the autologous types, on advantages and disadvantages that they have, and some conclusions on how do we support and guide our patient. Obviously, take everything with a bit of a grain of salt. I know different countries will have different approaches, different facilities. Obviously, I will speak on my experience coming from the country that I am and the access that we have to autologous reconstruction. So why choose breast reconstruction in general? Because often autologous reconstruction is a complex procedure, so I often have patients or friends or the nursing staff in the main operating room. Why do women choose so much surgery? Why do they go through this to have a breast? And whether it's implants or autologous reconstruction, every woman will have her own reasons. But I would say that they just want to move on, especially if it's a delayed reconstruction, if they've been living with a mastectomy scar. It's difficult for them to get back to life, fit into clothing, and what I find reconstruction gives them is control again of their body, being able to move on with life and forget and don't spend any more time thinking about cancer. We know that oncologically it's safe to do, it's associated with high satisfaction, improved psychosocial outcomes, and like we said, it's an integral part of breast cancer care. And that goes for both types of reconstruction, in implants and autologous. When it comes to Canada and how it's addressed, we have recommendations for immediate reconstruction being part of the initial diagnosis and part of at the time of the mastectomy. There's multidisciplinary clinics where you talk with your plastic surgeon, your general surgeon, your radiation oncologist, and you make a decision together about how to proceed. Our goals in general are to restore form and function. We want to do it in a way that the patient is, so when we evaluate it from a patient perspective, it's useful. We've done our job in terms of helping her get back to life and get back into clothing and have symmetry. In breast reconstruction, ideally, we want to provide the patient with a soft breast mount, symmetry in clothing, and minimize morbidity. That's key. So I tend to spend quite a bit of time building what I call realistic expectations. I tell my patients that I cannot replace what was taken away, that there will be differences in body image, especially if it's a unilateral reconstruction. Scars are permanent, especially the ones that I may add to do something to them. Sensation is not normal. And there are limitations and complications that exist with all forms of reconstruction. And I'm a firm believer of this, that there is no such thing as a gold standard. I don't think that if you can't have an implant or a flap, you're getting sort of a lesser approach and a lesser solution. Everyone is a bit different. We've talked about throughout the conference about individualized approach and all the types of treatments. So does for the same thing goes for reconstruction. It's very personal. And obviously can happen in the immediate setting as part of an oncoplastic approach. Maybe you're doing a therapeutic mastectomy reconstruction or a prophylactic mastectomy, or delayed after all the treatments. And there's going to be a big team involved with the patient trying to make the best decision possible, taking into account the stage, the urgency of adjuvant therapy, patient wishes, overall health. So we've talked briefly about alloplastic reconstruction. It can be two-stage, one stage with ADM. When it comes to autologous reconstruction using the patient's own tissue, it can come from the abdomen, it can come from the back, less commonly from the thighs, the gluteal region, and sometimes combination flap and implant. And just very briefly, as I'm going to be talking about autologous reconstruction, what can we do now? What's possible? You see here nipple-sparing mastectomy on the left in a BRCA patient with direct-to-implant. In the other picture, you see skin-sparing with 3D tattooing for the nipples, direct-to-implant. It was history of breast cancer on the left side. We're getting better and better at providing patients with good symmetry, especially in bilateral reconstruction. We're getting better in unilateral reconstructions, and again, you'll see a variety of pictures today. Some of them will not have a complete nipple reconstruction, the recent cases, but you have a picture here on the left. They're both, the one on your left is radiated on the one side. It's a skin-sparing mastectomy with a radiated expander that was exchanged to an implant, has a balancing augmentation, and on the other side is a non-radiated expander to implant and a breast lift. But we're getting good results with our autologous reconstruction. So I guess here on your left is an immediate DIEP. There's no revision surgery here yet. She needs a balancing procedure on the other side. She's decided to go ahead with more fat grafting in her normal breast. She likes the way the flap is sitting and the position and contour. The other case has a delayed reconstruction with a DIEP flap and a balancing reduction. She didn't want a nipple reconstruction. I mean, ultimately, you can't really tell what's under clothing and what patients are wearing, right? So I think it's important to realize that we as surgeons, as professionals, obviously we have a high standard in mind. We want to give the patient the best symmetry, but it's important to keep in mind what the patient wants and what they're happy with at the end. And as I'm going to be contrasting the autologous reconstruction, what I tell my patients is that if you have an option of both, the way to look at it is that implant-based reconstruction obviously is going to take less time, less complicated in terms of the recovery time, no additional scars. However, there will be disadvantages, such as there's a foreign body. You have frequent office visits. I tend to follow my implant patients once a year to make sure there's no issues. Minimum 2 surgeries. Even if you do everything in a direct-to-implant, you're coming back for fat grafting at least once, at least in my experience. It is difficult to match a natural breast, and there may be asymmetry over time and possible surgeries in the future. And that's where the implants become more complex, because you may have issues with them in the future, especially if radiation's in the... And it's all about expectations. If I tell them that expect a firmer than a natural breast, expect cold sensitivity, it may not age or move like a natural breast, patients do a lot better. If you're going to sell the implant as a natural soft breast mount, then they're not going to do very well, because that's not what it is. So autologous reconstruction is using patients' own tissue to restore a breast. Some consider it the gold standard. I don't think there's such thing. However, I do feel that autologous reconstruction can give a great result for the right patient. So obviously the flap can be transferred in a pedicled fashion. You don't have to restore the blood supply, or you can do it in a free tissue transfer where you're restoring the blood supply under a microscope. And you have the workhorse flaps, the latissimus dorsi flaps, the abdominal tissue transfers in the form of pedicle trams, free muscle-sparing trams, DIEPs, SIEAs, and less commonly used flaps from the gluteal region, thigh flaps, and the newest kid on the block, the lumbar artery perforator flap. So I'll mention all of them, spend a bit more time on the workhorse flaps as opposed to the last ones, and talk a little about the pluses and minuses. When it comes to autologous reconstruction, there's a lot of considerations in place. Patients' wishes. Plan for radiation if this is immediate reconstruction, or history of radiation. Does the patient even have extra tissue, and where does she have it? Will she accept additional scars? And that could be an issue. I mean, obviously, I come from Canada. We have winter most of the time of the year. We don't tend to be in bathing suits, so having scars in our body might not be as much of an issue, but that might be more of an issue here in Greece, and that's a very reasonable reason not to want to have scars anywhere else. The patient has to be medically fit. These are long, complex procedures. She needs to be willing to go through more upfront. So what I will say is that with an implant-based reconstruction, not a lot of upfront at the beginning, but maybe you'll have issues in the future. Whereas the autologous reconstruction, once you heal and once we've done our revision surgery, usually you're good for life. So patient selection, as with everything, is key. The patient needs to be medically fit. There's a lot of discussion about whether there's absolute or relative contraindications in doing free tissue transfers, especially. BMI, is there a cutoff? I mean, it depends who you ask. If you ask North American surgeons that have patients, the majority of them are of great BMI, they'll tell you there is no cutoff. However, so what I do in my practice for delayed reconstruction, where it's purely elective and they've done all the treatments, I try to avoid BMIs anything more than 32, 33. So if they need to lose weight, I make them lose weight. So that most of them, if they want to have breast reconstruction, they're willing to go through some work for it. If it's an immediate reconstruction, it depends on the patient. You may have a BMI of 35 and a very good patient that you know is going to get up and move quickly. Otherwise, anything more than 35, I think your risk of complications can go high. Issues like diabetes, hypertension, they need to be fairly well controlled. Coagulable states, if there's specific disorders, again, it all depends on the risk you want to take. You already have a stressful procedure ahead of you, so how stressful do you want to make it? Again, this can be elective, so I tend to not do surgery in people who have specific conditions with hypercoagulability. If they're on tamoxifen, I take them off for 2 to 3 weeks. If they're smoking, immediate reconstruction, I tend not to do it. If it's delayed, I tend to ask the patients to be off smoking for 2 to 3 months. So if there's history of previous surgeries, obviously if there are certain scars in certain areas of the body that prevent me from using certain blood vessels, maybe I need to investigate. It's very important in total to have a very well-informed consent with the patient. They need to know the risks, they need to know the benefits. They have to have realistic expectations of what they're getting into, and it's important to talk to them about alternate treatments. It's important to tell them what the result will be with an implant, because they may decide to go ahead with that. I've had patients where we've had a conversation, they decided on a DIP flap, they went away and they came back 5 days later and they said, you know, I thought about this. It's a lot of surgery. I don't want to go ahead with it. I prefer to go back with implants. But it's important to give them all the information so they can make the best decision for themselves. Now, advantages, well, traditionally, it will withstand radiation effects better. So in a radiated field, we prefer to put patients on tissue, or if we're going to put an implant, to couple it with some sort of patients on tissue, whether it's latissimus dorsi flap or a fat grafting injection, then it's something that we need to take care of, because just straight radiated field with a tissue expander or an implant definitely doesn't do very well. It is a softer breast mount. It resembles a natural breast much better. So if you have a unilateral reconstruction, obviously you can do a better job matching to a natural breast. It's long-lasting, and there is less risk of future surgeries. It still needs revisions. However, there may be less long-term issues. Challenges, disadvantages, however you want to call it. This is longer, so depending on what you're going to do, whether it's a pedicled flap or a free flap, it's more complex. It requires specialized surgical training. It's ideal to have a partner. Where I work, I have 2 partners. There's recovery pathways now. We try to, so this is a great option for the right patient, but you want to offer it in a safe manner. So if you can't offer it in a safe manner, maybe that's not the best thing for the patient. So if you follow, so we tend to follow specific recovery pathways. So patients are up in a chair the next day. They're walking by the end of the first day. They have a catheter out in this very specific moment. They tend to eat the second day. So there's very specific instructions that they follow so that they stay in the hospital maximum 3 to 5 days. And the recovery is about, in total, 2 to 3 months. Now, we talk to them about possibility of taking them back. It doesn't happen very often. Again, that has to do with selection of your patient for a partial total flap loss, which can be devastating, especially if you've been through that long process. Risk of DVTs and PEs are become more of an issue for these long procedures as opposed to the implants. And there is additional scars and donor site specific morbidities, and we'll go through that as we're going through the different flaps. Now, we've seen today radiation is expanding. There may be situations where we didn't think we were going to have radiation. Now we have it. We saw today how we're radiating before we do microsurgery. So we're going to see this in our pathway, and we're going to see this in our patients more and more. So you may have situations where you have reconstructive failure of implant-based reconstruction with radiation, and you're searching for a salvage situation, or a patient has had their implants and now they've had enough problems, and there comes a time where they don't want them anymore. So it's important to have other options for the patient. There can be challenges in radiation and anastomosis of recipient vessels. Fat necrosis risk can go up. Planned reconstruction, usually I do plan it about 6 to 9 months after after all the treatments are done, to try to get away from that early acute effect, even though maybe after the Prada trial that won't be the case. So the latissimus dorsi flap, pretty much workhorse flap. I used to do more of these at the beginning. We did a lot during residency, but we do less of them. Again, for the right patient, it could be a right option. I think it's important to keep options in our armamentarium and take them out as needed depending on the patient. So I used to traditionally, if I had a patient who didn't have an abdomen or didn't want autologous reconstruction from the abdomen as a free tissue transfer and had radiation and wanted an implant, I would just drape it with a latissimus dorsi flap. And it usually requires an implant, but sometimes now you can harvest it as an extended flap with more fat and make one. So yeah, picture on the left shows somebody with a previous lumpectomy. You see the scar on her left breast. And then she had recurrence, unfortunately, and all she wanted was to match the other side. So all we did was we brought the latissimus dorsi flap with a bit of extra fat, and you see the back skin there in the center. She didn't even want a tattoo. Are they symmetrical? No, but she had a natural soft breast. It was matching the other side fairly well in clothing, and that's where she stopped. The other picture shows a bit more traditional skin paddle that I put over an implant. This was somebody who had tried an implant in a radiated field without anything else, and she found it very, very tight, and she didn't want an abdominal procedure. So what we did is we brought the latissimus dorsi flap from the back with a skin paddle, and then that just gave her more central projection and more softness. These usually take 3 to 4 hours. It's an overnight stay in our institution. They don't involve microsurgery. This is a very reliable flap. There is a back scar. I know some surgeons will do them through the mastectomy fields. I haven't tried that, to tell you the truth. I find that this is easy to raise through the back, and the scar can be well hidden. But again, maybe for Canadian patients, that's considered okay. So seromas can happen. It may worsen lymphedema. It's rare, but it can happen. And unless you're a competitive skier, climber, a swimmer, this is not a problem with normal activity. Abdominal tissue transfer. And I would say that that's the gold standard of autologous reconstruction. That I can say. So obviously has evolved. We've gone from the pedicle tram that you all know to the free muscle-sparing tram, the free DIEP, the SIA, all evolving from a need to try to minimize that abdominal wall morbidity. And I haven't done very few. We've done a couple of SIAs, but that's only in the case where you actually encounter big vessels. And you find that even if they are big vessels, when you cut the lumen and you see it under the microscope, it's a lot smaller than you thought it was. So I tend to almost always go for a DIP flap. And I only do a muscle-sparing tram if I have a problem with the number of the vessels that I want to use. So what I do is I usually identify all the perforators, and then I actually clamp around and see which ones will perfuse the size of flap that I want. And I only use those. If I need to take a little bit of muscle around them with them, then I do. And I usually connect to the internal mammary artery and vein, rarely to the thoracodorsals. So evolution again to the free DIEP to minimize abdominal wall morbidity, but again, there is still a risk of hernia and bulge, even though it's smaller. The abdominal wall strength does, for a unilateral pedicle tram, which I still will do for a select number of cases, within a year I find that they normalize, they don't have a problem. If you have a strong mesh closure, they do very well. Obviously for bilateral cases, I'll tend to do free tissue transfer. The abdominal scar is not a cosmetic abdominoplasty scar. So patients will come and they say, well, I'm here for the tummy tuck, the one that gives you the tummy tuck, and then I get the tissue to the breast. Well, this is not a cosmetic tummy tuck. This scar is placed a bit higher, that you may have had previous surgery that may have damaged the perforator vessels. So often we need to do preoperative imaging to make sure that there are some available. Some examples, so this is one-sided DIEP flap on the one that had the previous lumpectomy and radiation, and there's a small implant on the other side to balance. This is a DIEP bilateral immediate with nipple tattooing and reconstruction. This is an example of a one-sided immediate, the other side delayed. So you can see the difference. Obviously, if you're missing the breast tissue, you're going to have to make for that through the abdominal skin, and that's where you're going to see. But the color match of the abdomen and the chest can be quite good. Can you tell which one's pedicle, which one's free? Sorry, I'll go back. The one on your left is a pedicle tram for an immediate reconstruction. The other one is a free DIEP. Again, these are fairly early. The one is only 6 months old, the free DIP flap. Again, it all depends on what you're trying to achieve. And the patient on that chose the pedicled one, she was in her 70s. She didn't want a 6-hour surgery. She didn't want to stay in the hospital for very long. You know, she had an overall fairly normal activity level, so she wasn't concerned about being able to do yoga or other hardcore abdominal exercises. So I think, again, it's all about keeping the tools in your armamentarium and, depending on the patient, pick the right procedure for them. So what happens when you don't have an abdomen available, or you've used the abdomen, or it's somebody who, like the one on, you see the picture on the C, is somebody who's had a DIEP flap reconstruction, there's no more left to use. The one in the middle doesn't have a very big abdomen, but has a nice sized breast that she wants to match, and the person in A is quite small. What happens in these situations where the patient still wants autologous reconstruction? Are there any other options? And these can be difficult cases, because I can tell you, we don't have a lot of experience with other autologous sources. You have the big groups across the world that do the thigh flaps, and the gluteal flaps, but unless you have a specific experience with them, you just have to find the right patient to try something like this. I included them for completion. I don't have a lot of personal experience with them. There's a bit of a learning curve. There's preoperative imaging almost always to identify perforators. Some of them can be tedious in terms of dissection with need for vein grafts. You have to reposition the patient a number of times depending on what you're using. And even these groups that do these regularly, they don't compare the result that an abdominal free tissue transfer can give you. So just as examples here, obviously this is made popular by Dr. Allen in New York, the S-gap or I-gap flaps, and you can tell, I mean, you can imagine, especially doing a bilateral reconstruction like this, you have to reposition the patient almost 4 times, and that will add hours to your surgery. And these can be tedious dissections. Pedicles can be quite short. Sometimes you need vein grafts. And the scars, well, it's up to your patient, right? You have to show them these pictures so that they know what to expect. Would they like an I-gap scar better? I don't know. It'll have to be a personal choice. The other thing with gluteal fat is that it's tough. It's not comparable to the abdominal fat. So you can't shape it as easily. You tend to use a lot more fat grafting sessions to get to a nice result. The intramuscular dissection can be a problem. Positioning increases the time. And sometimes in I-gap, what surgeons who have done them notice that you're trying to get more tissue to make a bigger breast, but then you can actually injure sciatic nerve branches, and that cannot be good for the patient. Medial thigh flaps, again, so there's more popularity to them. I think they're doing them a lot more in Germany, certain groups. They're named depending on the design of your paddle on the thigh. They can have some skin necrosis depending on how big that is designed. They can have spreading of the labia majora, lower limb lymphedema. Sometimes you can have paresthesias in the posterior femoral cutaneous nerve, and often you need to stack them. Again, these are not very big flaps, and again, you may have the body shape of a particular patient that may lend to this, but you have to sort of decide that, and it's going to have to be a decision between you and the patient, because she's going to have an acceptable scar to her. Just some pictures of transverse ones and vertical. And this is posterior thigh flap, so just looking at the patient from behind based on the profunda artery. Again, there can be different skin paddles that you can design depending on the size of the flap that you need and the size of the patient. Lateral thigh flap, again, you're going to have, this is a patient straight from a paper. Again, I don't see a lot of these. This is somebody who had nipple-sparing mastectomy, implant-based reconstruction, lots of problems with her implant on the one side. She was looking for a different solution, not a lot of abdomen. This is a bilateral lateral thigh. You see the scar here. Yes, looking at her right here, you can see there's a bit of a pear shape. There may be some tissue here. You can see the scar. To her, it's probably an acceptable result because she now has soft breast mounts. She doesn't have to worry about the implants. But again, it has to be the right patient. The lumbar artery perforator flap, again, pretty sightly. The scar is pretty high up. You can see it here. Outside even conventional clothing here on and underwear. But again, it all depends on the body of the patient. She may not have medial thigh, or maybe that's not what she wants the scar. It's a very personal choice. So it can be a great option for the right patient. It's one of my favorite operations to do, but I don't sort of sell it to the patient. I try to pick the right patient, the patient who wants to go through this and is a good candidate for it. It requires training, ideal to have a setting of a breast center. You want to have a partner. These are not fun, especially if they don't go well. You want to have somebody with you. Enhanced recovery pathways are getting more and more commonly implemented, so to make sure that this is done safely and efficiently. Now, it's interesting. So patients tend to score better when it comes to autologous reconstruction in the breast Q. And again, that doesn't say necessarily, doesn't mean that everyone should have this. But what it says is that people who have, the patients who have it tend to do well with it and they're happy with this result. I was surprised by the survey that was done in 2009 that actually asked female plastic surgeons what they would choose. And you know, when it comes to female plastic surgeons, obviously we know a lot about these procedures. We have good knowledge of what it means, the risks. I'm not sure whether it was surprising or not, but the majority of them, it was 60-40 split, chose implant-based reconstruction, citing complexity and donor side morbidity issues as a problem, and that's why they wouldn't choose it. And that's important to take into consideration. So it's important not to be impartial. Don't favor one type versus the other. You're there as a breast reconstructive surgeon. Obviously, it has to do with what you can offer them as well. If you can offer them a certain option well and you think that they can be a good candidate for it, then you're going to argue for it. But we try to educate our patients on the different options, advantages, disadvantages. It's our job to make sure that they know of any absolute contraindications. If you think it's a bad idea because they're smoking or there'll be a higher chance of flap failure, then you're not doing them any favors by allowing them to have this operation. So we have to individualize the choice. So in an ideal world, options would be available in an appropriate setting of a breast center, covered by an insurance, public health system. I know that's not the case across the world. Multidisciplinary clinics are good. They're good for education of the patients, and it's good for them to make a plan with the entire team. Now, fat grafting has definitely, we'll talk about this a little bit later, has revolutionized breast reconstruction. You have more of an option to combat radiation effects and still put an implant instead of going through a complex procedure. So it can be another tool. So we're at a point where we're very fortunate to have lots of options available to our patients. We talked before about prepectoral reconstruction, so even implant reconstruction is undergoing a lot of evolution. We just need to make sure that we optimize any modifiable factors for the autologous reconstruction, order the appropriate imaging to help us with planning, and choose delayed reconstruction. Sometimes I don't have any problems. If I think a patient will be a good candidate for DIP flap and she's not keen on an immediate reconstruction, I think she can have a good result later, I will discuss this with her and ask her whether she would be willing to wait. Some are, some aren't. So offer safe options, set realistic expectations. Pushing the envelope, trying new flaps, trying new things, it's a learning curve. You have to embrace it and you have to pick the right patient. I had a patient, I'll close with this case. She came to me, she had a large breast on one side, radiation on the other side. She was keen on using her own tissue. I looked at the abdomen. She had a midline scar below the umbilicus, another scar going across a C-section type scar. The first thought was like, no, there's no way we're doing this. But, you know, at some point you need to plan and see whether you can try something for the right patient. And I did a CT angiogram. She had perforators on both sides. I explained to her that the only way to do this would be to actually raise both sides of the abdomen and do it as a stacked flap option, so to connect both of them in the internal mammary artery and vein. I told her that that was not something that I had done before. I've done lots of regular DIP flaps, but not combined. Obviously, in terms of the technique, it didn't really add more complexity, but it was something different. So she was happy to try. We did this. This is 6 months later. She hasn't had her balancing reduction on the other side, but I argue a fairly good result. So this is the entire abdomen raised with two pedicles, essentially. One is anterograde connected, and the other one is retrograde along the internal mammary artery and vein. Again, it's a learning curve. I'm in my 4th year of practice now. I try to learn as I go and try to offer the best thing for my patient. I'm happy to offer, I do a fairly even split of implants and flaps, so I'm in a country that obviously covers all these procedures and allows me to offer my patients what I think is best for them. Thank you for your attention.